Hello, everyone. Welcome to the first Accelerating Healthcare Access webinar. We're so glad that you could join us. I am Ashwin Naik, the moderator for the discussion today. I'm an Ashoka fellow and a healthcare entrepreneur working in the space of primary and secondary health. And to begin with, let me give you a brief introduction to the Accelerating Healthcare Access program. Philips Foundation, Ashoka, Royal Philips, and other leading organizations are combining our strengths and expertise to create solutions to some of the most pressing healthcare-related problems in the developing countries. Philips Foundation's mission is to reduce health inequity by providing access to quality healthcare for disadvantaged communities. They are responding to this great urgent need by expanding access to quality healthcare, by deploying Philips expertise, developing innovative products and solutions, and by collaborating with various organizations like UNICEF and Red Cross. Ashoka, as many of you know, is an international organization which supports and connects in more than 90 countries about 4,000 top social entrepreneurs around the world. These fellows work around multiple areas: health, education, environment, gender, equality, and more. Ashoka is also working to create an everyone a change maker world where each person finds their own power for good by mastering empathy, teamwork, leadership, and change making. The Philips Foundation and Ashoka have come together as we feel that we have a significant common ground in the fact that we are both interested in supporting movements that are sustainable and can be scaled to a country level or a continental level. We are excited to join our unique perspectives and experience in this accelerating healthcare access collaboration. The purpose of this webinar series is to explore unique challenges that primary care, particularly in developing countries, is facing, but also looking at how leading social entrepreneurs and business professionals are creating innovative solutions to overcome these barriers. In this, we present first-hand accounts from practitioners and other experts, and we also invite questions and comments from you as participants. The first webinar is focused on maternal and child health, and we are specifically looking at the problem of infant deaths and what are the technology solutions available to reduce unnecessary deaths in infants and mothers. And given that this is the UNGA week and WHO and other organizations have made a declaration on universal health access, the topic of maternal and child health is continuing to be of great importance for us and for others. So we are so happy that more than 200 of you have registered for this webinar. While I start with the speakers and panelists, I encourage you to think of questions that you want to pose to the speakers. You can add those questions in the Q&A box on your screen, and we will take up as many as possible during the end of this webinar. I'm very excited to be joined by 4 great speakers from different geographies. Dr. Queen Dube is joining us from Malawi. Hilmi Quraishi is joining us from India. We have Ankur Kaul joining us from India again, and Dr. Jeffrey Smith from the United States. Dr. Queen, maybe you can tell us a little bit about what you do, but specifically we'll be very interested to hear about your experience in developing the innovation ecosystem using technology at the Queen Elizabeth Central Hospital.
I work with this amazing team, and our goal really is to come up with technologies that are tailor-made for environments like ours, where technologies that are used in the developed setting, for one reason or the other, fail. So sub-Saharan Africa, 1 million babies, newborns die every year, and they die from the same causes as everybody else has known. What actually can prevent these deaths, we've known it for several decades. The biggest question has been, how do you exactly do it? How do you make it happen within our settings? So I work at a tertiary facility. I also work in the district hospitals in Malawi. And one of the things that we noticed are 4 major gaps, the technology gap, the human resource gap, the implementation gap, the how to do it, and then the market gap. Malawi is one of the countries that relies very much on donated equipment. And this is equipment, very expensive pieces of equipment. We get it, we use it for a few weeks, it breaks down, we don't have the capacity to actually maintain it. And so what we figured out over the past several years is you really need a different solution for countries like Malawi. You need to come up with technologies that are effective, technologies that are affordable, and technologies that are sustainable. You don't want technologies that would work in a project mode. You want something that is sustainable, embedded in the system, something that would work bearing in mind that you have 2 nurses looking after 50 babies. So having that at the back of your mind, technologies that withstand the heat, the dust, and the frequent power outages. So the sustainability piece is not just about financing, but also, in terms of the technical know-how, how to maintain these, but also something that would withstand the harsh African environment. So we've, over the past decade, we've, embarked on this journey. We started with one technology, the bubble CPAP machine, we call it Pumani. And over time, we've come up with, other pieces of technologies. But the biggest learning point for us, because we started this collaboration with our friends in the United States, but the biggest learning point was we needed to develop local capacity. And so introduction of a biomedical engineering course by our local university was one of the game changers. As I speak now, there are pieces of technology like phototherapy lights that we use in our units that are locally innovated and locally manufactured. For us, this is where Africa should be heading to, not just looking up, to the developed setting, but looking at homegrown talent. How can we best use homegrown talent to solve local challenges? Thank you.
Thank you. Thank you, Dr. Quinn. Now, just to build on that answer, you said that the local context, the local environment is very important, but where do you start? I'm assuming that when you began, this was a huge challenge because you have to build every piece of this puzzle from ground up. How do you start building these ecosystems? Did you start with the hospital, or did you have a team work on this? How do these innovations start in a hospital setting like yours?
It actually started with some crazy clinicians. Some years back, we used to do our pediatrics training outside the country. And so lo and behold, you get exposed to this fancy technology. You realize that, you can have a baby 500 grams and they survive. And you think back, you were losing 1.5 kilo babies in your own setting. So when you come back home, reality hits you. And so it started with a small group of clinicians. We had these pictures at the back of our minds, and we would innovate for what we called at that time CPAP machines. So simple bottle, put some sterile water there, add some tubings, make it bubble in one way or the other. And we thought, we're giving CPAP. And actually, we were not giving CPAP, to be honest. But sometimes you do things that keep the hope alive. And in the middle of that, we had these 2 visiting professors from the US. It was their first time in Malawi. I don't know up until today why they came at that time. And they were busy asking questions, typical engineers. Do you have challenges we need to solve? And we said, of course, yes. And we pointed them to this, what we called our CPAP machine. They were very polite, and they went back. And we worked together step by step in developing different prototypes up until we got to a point where we had the commercial device. Along the path, we then had other people joining. And it was through this collaboration with these engineers from the US that we realized that, no, we needed to find our own local engineers. So we went to the engineering school, And, to cut the long story short, we're now at a stage where they join us during our ward rounds, the engineering students, the lecturers. They join not every day, they can come once a week. And then at the end of the ward round, we sit down together, we brainstorm, and then we have one problem that we want to solve at a time. Some of them are like undergraduate challenges, some of them are postgraduate challenges. And for us, it's this link with engineering school where you are able to hold each other's hand and try and solve these local problems. And it's just been a fantastic, past 3-4 years. As I speak now, we now have a second engineering school that has introduced a biomedical engineering course. And we're looking forward that we should have things like these across the country.
Great. Thank you. You spoke about two things. One is contextual technology, and the second is the power of collaboration. Maybe I can bring Ankur in at this point. Maybe you can talk a little bit about the technology that you have or working on, and also share your insights on how this pans out.
Sure, Ashwin. So I think, if you look at from a Philips perspective, the whole focus on primary care in emerging market comes from our larger vision for the company, which is to improve the lives of 3 billion people by 2030, right? And if you look at where we are today, if you look at the lives improved numbers, we are at about 2.2 billion, largely focused at the developed world, North America, Western Europe. So if we are really to bridge that gap and get to that last billion, it's really going to come from markets like countries in Africa, countries in Southeast Asia, countries in Latin America, because that's where access to care still remains a really big challenge. Right, so we come from that focus on strengthening primary care, and what we have today in terms of solutions is a solution called as a community life center, where we actually set up ground up primary health facilities in areas where today the primary health system is broken. So I think if you look at across all of these countries that I mentioned, one of the biggest challenges is that primary healthcare is broken, and what tends to happen is that anybody with a small ailment like a cough or a cold tends to go to a secondary or a tertiary care hospital, hence overburdening those facilities where specialists are spending their time looking at cases which they should not be really. So what we are trying to do with the community life center is to strengthen primary care by setting up these centers. These could be greenfield, set up from ground up. These could be brownfield, where we take existing government centers and really refurbish them to get them to dispense the right quality of care. And particularly within that space, we have a solution called as MOM, Mobile Obstetrics Monitoring, which is focused around early detection of antenatal high risk cases, and really with the vision of covering the first 1,000 days of life. Right, and the way we do that is that we digitize the whole journey of this woman from the time she conceives, the whole pregnancy journey, and then shifting into the intrapartum journey, which is covering the labor and delivery phase, and then moving on, to the postpartum journey, which is the journey of the mother till the time the child is 2 years of age. And this is what we really cover through the MOM solution. By empowering the community health workers to collect data in an offline app, we have certain algorithms running on the cloud that, based on the history, the examination, the investigation data that's collected, can then tell you whether this is a low, medium, or a high-risk pregnancy. We have a very tight integration with our ultrasound. So if you do an ultrasound scan, those images can be attached to the digital profile, and then really any obstetrician sitting from anywhere in the world can view these images. And I think one of the things that you asked about, which is how do you ensure that these are still relevant to the local context? And I think this is where we really work closely and co-create these solutions with our clinical partners on the ground. So to give you a few examples, we work very closely with Dr. Marlene Temmerman, who heads mother and child care at Aga Khan University in Nairobi, to ensure that these solutions are a good fit for the local context there. We have another clinical partner, Bunda Medic in Indonesia, for example, where we work with Dr. Ivan. So while we may reuse some of these WHO protocols, we always ensure that we have a clinical partner from the local setting involved to ensure that these solutions are locally relevant and are able to, in fact, solve some of the main challenges that we face on the ground through the use of these solutions. And I think everybody here on the panel, right, Dr. Queen, who's on the ground, Jeff and Hilmi, they'll agree that there are a lot of challenges. And if I was to just give it an acronym, we call it the 3 I's, just so that it's easy to remember. It's infrastructure, investment, and incentive. That's how I look at it from my own personal experience. In terms of infrastructure, when we talk about primary care facilities in remote areas, internet connectivity is something that you can't take for granted. At best, it is intermittent, if available at all. Power backups are not easily available. So when you introduce digital solution in an environment like this, there are a lot of challenges. So you have to come up with innovative solutions like offline apps. Your apps need to be offline so that people can continue to use and fill data in, whether there is internet, yes or no, and you need to be on devices that are charged and that can retain charge while power is not available. And then also there's a huge challenge of human resource, right? And I think Dr. Queen touched upon it. Like if you have one nurse looking at 3 women in labor at the same time, it's impossible to expect this person to then have the time to enter data in a digital system. It's simply not going to work. So how do you overcome challenges like this? You need somebody, and this is what we've done in some of our centers in South Africa and Kenya, is to have an admin or a data entry operator, an intern, who can shadow the nurse and enter data into the system to ensure that you're getting good quality data in while care is being dispensed, right? So that's around infrastructure. When I say investment, I mean, because I come from a private company and we have this vision of improving lives, but we still need to operate in an area where we can make ourselves commercially viable and just at least stand on our own feet and make these solutions sustainable, right? And this is where we need to liaise with the government very closely to have the right policies in place that encourage private sector participation, because one thing we all agree with is that no one person or one company can solve these problems alone, right? We need the ecosystem, we need everybody to come together, whether it's public, private, and hence that importance on investments. And the last thing is incentive, right? And I think the challenges we face there is, what is the incentive for people to enter data into these digital systems, right? Why should they do it? The only reason they'll do it is they see real value that it adds. So for example, using our mom solution, there are specialists based out of Jakarta today reviewing pregnancies in Papua, which is like a 5-hour flight away from Jakarta, but they are able to give an expert opinion on and a specialist where a specialist would otherwise never be available on the ground to do that, right? So when somebody sees a value in that, you have the right incentives for them to use the system. So which is why incentives become important. And as we move towards value-based care, when more and more reimbursements are being linked to clinical outcomes, the importance of digital systems just become really, really, really high, right? And once we have these incentives in place where people are encouraged to enter good quality data because the reimbursements and outcomes are linked to it, then we really have the perfect ecosystem where you have all of these 3 I's, together. Yeah.
Thank you, Ankur. I think very interesting thoughts on infrastructure, investment, and incentive. Also, your thoughts on working with the government clearly is a big challenge that we see. Maybe at this point we can bring in Hilmi if he's on. Hilmi works across multiple geographies, largely partnering with governments. So it'll be great to get his perspective.
I'm Hilmi. I'm co-founder of ZDQ, a technology for development social enterprise, which exists for the last 20 years, and we work in multiple geographies. We have scaled our program from India to Afghanistan, Uganda, and Rwanda, and now planning to go to West Africa. So, it is, into maternal and child health has been having one of our areas, a deep interest and passion, and our objective is basically is to strengthen the last mile health system. When we talk of strengthening the last mile health system, it is about at the bottom of the pyramid, so how can the information reach to the last home, or, in a village, and how to train, empower the community health workers so they are able to take information to the last person on the ground. So it is more about behavior change. It is giving right information at the right time, and then giving the access to the healthcare service, so that a timely healthcare service is being given to them, so that we're able to save the lives. Our program of MIRA has started in 2012, which is basically an integrated model on maternal and child health, and it has multiple channels on prenatal care, postnatal care, immunization, and we touched also upon adolescent girls and family planning, because it works in a life cycle approach, where we take the complete life of a girl, being adolescent, then being a mother, and then where she needs the family planning services. So here we use a lot. Our innovation talks about health communication, health tracking, and delivery at the public health service. In terms of health communication, we use smart tools, but it is all animated, and it works like a talking toolkit, because here it is expected that here majority of our beneficiaries are semi-literate or illiterate women, and they don't know how to read and write. So it works as a talking toolkit for those millions of women who can't read and write. And then we use a lot of gamification also, where we have inbuilt trackers, calculator, analyzer, which can give you instant information. For example, what a woman should be doing in a particular week of a pregnancy, what she should be eating in terms of dietary information, in terms of her medical health, in terms of do's and don'ts, everything. And also we are able to also connect with the midwives to get as we have live data system here, so every information is point live, and we have live dashboard which gives you instantly every information of every woman at a particular moment of time. So it helps in identifying high risk cases at a very early stage, and they can be referred to the systems. So it is basically working at the bottom of the pyramid, and our linkages are up to the PhD level, like 3, 2, or 4.
Okay, Hilmi, just to build on that, you started from India, but now you're in multiple countries. As you scale your solution and your platform, what kind of local challenges, both political, geographical, and social differences that you see, and how do you resolve those as you go into multiple countries?
Yeah, see, as we go into multiple countries, as first and the foremost is that you should have an agreement with the government, because it is not something which we are trying to do as a pilot in a small zone. We must start with a district or so, but objective is to go up and scale it. So being part of the government system is very, very important, and especially in every African country, we have something called e-health working group, where you have to present there and be part of the system. Also, as you start working, our objective is to empower a local community NGO or a CSO who can run the program, at a very low cost and for a long term of time. Because at the end of the moment, at the end of the day, either we or any international organization, they are going to exit the ground, but the idea is to build the local capacity so that they can run it for a long time, and we have to build a model that it becomes really cost effective. So either they have some kind of monetary benefit there, or the government might find it very, very lucrative, and they put their own funds to run the program. So our challenges are that we have to work with the local partners and work with them also to develop the local content, because every content has to customize, and it has to be it has to be contextualized as per the local needs. At times it has to be very at times, for example, if you work in Afghanistan, even if sometimes you have to be very, very also very sensitive about the appropriate content, because it might hurt the feelings of the communities also.
Yeah. Thank you, Hilmi. I think there's a recurrent theme in all your insights, which is the power of local partnerships, contextualization, and working with government. Let me switch over to Dr. Jeffrey Smith and get his perspective from a macro view. You know, there is a clear need for collaboration at the grassroots level, but is there also a need for collaboration at the macro level, investors, businesses, governments coming together to solve this problem of healthcare access, particularly in emerging markets?
Absolutely. Thank you very much, Ashwin, and good morning, good afternoon, good evening to everybody. I'm in New York this week on the sidelines of the UN General Assembly and addressing exactly what Ashwin just mentioned. How do we take the bright ideas of entrepreneurs like Hilmi and Queen and join them with the savvy and the business perspective and the government perspective of people from around the world in order to reach the maximum number of women and children? I think you can only do that through partnership. As a donor, the Gates Foundation really looks to develop novel solutions and take risks that some other people can't take. We have the flexibility to be able to look at challenges and problems and dig deep and address some of the risks. And then when we have de-risked something through partners and through testing things in the actual environments where they need to be implemented, then it's our responsibility to join with other partners and build coalitions. I think any good solution does not reach its maximum potential if it only touches the lives of a few people. We need to join with global agencies like the UN, UNICEF, UNFPA, WHO, business partners like Philips and others, but also the governments in the countries where we seek to have impact, and the clinicians who are actually using the devices on the ground. So building that partnership and those alliances is really critical for moving these new innovations and these new solutions from the idea stage through the contextualization stage to the country context and then to global impact. So every step along that implementation chain really requires the insight and the perspectives of many different diverse people and many different partners.
Thank you, Jeff. Can you point towards some of the discussions that are going on to get this started? I saw that the 12 multinational organizations have signed a Health for All, Well-being for All declaration. Anything that you can point towards in the maternal and child health, which is emerging out of your discussions?
Yes, absolutely. The declarations and the discussions addressed here in New York this week have really been around universal health coverage. And that is ensuring that systems and processes are put in place in every community to ensure that all people have access to healthcare. And the foundation of that, the cornerstone, is primary healthcare. As Ankur spoke about, how do we look at those solutions that can be closest to people so that we can both address preventative health needs as well as curative health needs? And then how do those things move up the healthcare system if the illness is a bit more complex? So mothers and children are the primary users of primary healthcare services and are primary beneficiaries of universal health coverage. So the discussions here in New York and around the world about this topic of universal health coverage really are ensuring that mothers and children can get the preventative and the curative services that they need. And I think that's something that all governments can sign on to. But then once they've signed on to it, we as a global community have an obligation to help them, not only help them fulfill their vision, but also hold them accountable for the commitments that they've made.
Thank you, Jeff. Now, while the collaboration both at the grassroots level and at the, let's say, the investor or the multilateral agencies level is critical, there's always this question of capital. Now, how do we get countries to the same level playing field if capital is a constraint to implement these programs? So my question to you, Jeff, is capital the biggest constraint, or there are other challenges beyond capital that we also need to solve?
Thanks. The capital is certainly an issue that needs to be considered in implementation of any solution. Ankur was absolutely right. You have to talk about infrastructure. We can do the very best in training. We can do the very best in improving services. But if we don't have running water, if we don't have electricity, if we don't have a building in which the healthcare workers can provide care, then we're really not we're not developing a health system that's really robust and able to serve the needs of the people. I think capital can come in many different forms. It can be seed capital that the Bill and Melinda Gates Foundation often provides to help de-risk a solution and take do that early prototyping that Queen talked about when they were trying to figure out the way that the bubble CPAP machine could work. I think it's the kind of capital that Philips provide when they're looking at entrepreneurial approaches and solutions that can reach higher numbers of people. But ultimately, it's the capital that governments provide. And that really is dependent upon them seeing the value of the solutions that are being proposed. If we can't help them identify how this solution solves the problem that is affecting their people, and not just the Ministry of Health, but also the Ministry of Finance, the Ministry of Education, we have to work cross-sectorally in order to help stimulate the thinking about the value chain of these solutions.
Great. Jeff, just a follow-on question. Because you are in New York and you are at the UNGA, we have a question from a participant who wants to know a little bit more about the Universal Health Care Agreement, which has been signed by the multilateral agencies, and what does it mean? Maybe a line or two about that.
So I am certainly not a government representative, so I wasn't in the room as it was signed. But fundamentally, the idea of universal health coverage is helping every country in the world keep its commitments towards the Sustainable Development Goals. The global community years ago committed to the Millennium Development Goals, and that period took us through 2015. And then in 2015, the global community signed on for achieving the Sustainable Development Goals. And Sustainable Development Goal number 3 is about health and wellness. And so the commitment to universal health coverage is an effort to help all countries support their people to achieve the reductions in mortality and the improvements in health that have been committed to as a part of Sustainable Development Goal number 3. So universal health coverage is a step towards that.
Yeah. And also just to add to that, I think what was very interesting when these 12 organizations, including WHO, UNDP, and the others signed for this pledge, I think the big role was played by UNICEF, which represented the voice of the children, and particularly about how universal health access is critical for their well-being, and goes to your point earlier about how primary care is most often accessed by women and children. So we're very excited to see what comes out of this. Now let me switch over to Dr. Queen, because Jeff, you touched upon a very important point, which is about the human resource challenge. In addition to capital, there's also a big human resource challenge. So how do we create capacity to adopt this technology that is coming out, particularly in clinical settings like Dr. Queen is working on?
Every time I look at this human resource challenge, I look at it actually in two different fronts. You have the challenge with the numbers, and then you have a challenge with the capacity of the ones that you have. Now, the challenge with numbers, you can't sort it out overnight. You need to work with governments, other stakeholders, to have a good national plan over a period of time to make sure that over the next 5-10 years, you increase your numbers and you're able to sustain, because training is one thing, but also sustaining them in the system is another. You can train thousands and thousands and only retain 10%. So the issue around sustaining the numbers is another big challenge that we're working on together with our government to try and figure out a way of retaining these young, fantastic clinicians, nurses, and engineers in the system. What we're working on as an immediate solution is the second category, the ones we have now, the ones that are in training at the moment. How do you build capacity? And so we've developed what we're calling the COIN course, COIN standing for Care of the Young Infant and the Newborn. It handles most of the issues around essential newborn care, comprehensive newborn care. But the exciting bit within the COIN course is the issue around preventive maintenance. So we've put in modules that will teach a nurse, will teach a doctor, simple things around preventive maintenance for the pieces of technologies that are available or are soon to be available in our system. We've also gone ahead to introduce what we're calling clinical skills laboratories in our training institutions. This is something that you see in the developed setting. What we're trying to do is, whilst this nurse is still in training, let them be exposed to these pieces of technology within their institution in the clinical skills laboratory. So when they end up, they finally graduate, they come within a hospital setting, they're then able to continue using the piece of technology on patients. The third thing that we've done is to introduce what we call a mentorship approach. So it's both off-site and on-site. Because if it's somebody working, say, for example, at a less busy district hospital, chances that they will become confident in using certain pieces of technology that are probably on the lower side versus somebody who is working in a high burden tertiary facility. So we have a mentorship approach where you have pediatricians visiting these district hospitals, but we also bring these nurses and clinicians working at a district hospital to this tertiary facility. They work alongside us for a week, 2 weeks, for them to get this practical experience. And then the fourth angle around this capacity building is we've built in what we call learning sessions, where you bring together people from different facilities, different district hospitals. They come together, they present their data. Because one of the things that we've actually come to realize is the power of data. That the people on the ground are able to look at their own data, they're able to do some little QI activities and come back after some months, look again whether there's been improvements. So we've used the same approach and pushed it within what we call these learning sessions, where then districts learn from one another, because sometimes when you're in your little corner, you think this is impossible. And then you realize that a colleague in District X with bigger problems are actually able to solve it. So with these 4 different approaches, leveraging the QED framework, we've actually been able to capacity build even young nurse technicians, registered nurses, to be able to make decisions. So we don't have a lot of doctors in Malawi. So we have to rely heavily on the nurses that are our frontline soldiers. So, train them, give them the capacity to be able to examine a baby and say, you know what, I think this baby, I need to put them on CPAP. This is how I should monitor them. It takes time. But if you put everything else together, these 4 different approaches, we've been able to see a reduction in inpatient deaths in some of our facilities. And we think if you can replicate this within the sub-Saharan region, we should be able to get somewhere in as far as acceleration of neonatal mortality is concerned. So, we have this short-term goal, and then we have the long-term goal that we're working together with our government, both Ministry of Health, Ministry of Education, to try and figure out what is it that needs to be done to increase the numbers and also sustain them in the system.
Thank you, Dr. Quinn. I think when you started your comments, you spoke about the context, the local context, and then Hilmi touched upon the local culture. Now you're talking about capacity. So in addition to Ankur's 3I, we have 3 Cs, culture, context, and capacity. And I think one of the important points that you made now is about the relevance and importance of data. So let me take that question to Hilmi, because during his work with multiple community health workers and people in the field, I'm sure there's a whole lot of data that he's able to capture. So Hilmi, can you share what kind of impact have you seen based on the data that your platform is capturing?
In a program, a community health worker works, he or she has to visit the community person, especially the beneficiary, once in a fortnight, and they, and they demonstrate them all the aspects of of healthcare in terms of pregnancy, what all they have to do, and they also ask them high risk questions, which and a woman has to just answer in yes and no. And every event is being captured. Even, for example, a particular page has been shown to her. For example, a particular animation has been shown to her. Everything, is taken up as the data that, for example, how many minutes a patient or beneficiary has spent time on particular, for example, animation on a particular learning, and what has been the outcome, what has been the answer to the particular question. So all the data is with us, and it really helps us to take especially for the state to take a decision, because at every moment we can see, for example, which person has been accessed, which has not been accessed, and, for example, why this woman has not been accessed. For example, either it is the fault of the community health worker, or the woman was not available at home, or of some other reason. So if you see, we have a multiple range of data, right from visits up to the health status, up to clinical data, and it really helps the team at the at the state level or at the district level to see, for example, a woman who is visit twice for ANC checkups, she will not be in an extreme position at the time of delivery. For example, at the time her risk will be lower. For example, a woman who has not been at all attended the ANC checkup, she might end up in some kind of risk at the time of delivery. So here we are able to collate the data. For example, based on the visits, we are able to find out what will be the status of the woman at the in the 9 months of her delivery, or so here we are now building an AI platform, also artificial intelligence, where we're based on so much already we have more than 80,000 cases of data of 9 months of women in India, almost 30,000 of data sets of women who have been given services in Afghanistan, Uganda, and Rwanda. And based on that, we are creating an AI system to see, for example, if a particular symptom has been found out, for example, in the 10th or 12th week of her pregnancy, we can find that this is going to be the outcome at the at the time of delivery, and we are at the moment building that AI system as well.
Great, excellent. So maybe Ankur, you can weigh in on this issue of data, and particularly in the context of what you're doing with the MOM project, but also your work with other entrepreneurs in the ecosystem. I know Philips works with multiple entrepreneurs through your Health Works program. How are you seeing the role of data to design better products, and also to touch upon what Hilmi just mentioned, the emerging role of technologies like artificial intelligence in building better products, but more importantly, accelerating access to healthcare?
Good quality data is critical, right? And I stress on the word good here because often, systems are only as good as what is being fed in, right? So if it's garbage in, it's garbage out, right? So what I think is the big challenge is, how do you ensure that you can get good quality data into these systems so that the analysis and all the things that Hilmi spoke about comes out with the right insights, right? And I think that part is crucial, and I think that's a part today that still needs to be solved well, and we focus a lot on that in terms of how do you ensure that good quality data gets fed into these systems. But once you have that good quality of data in, then of course it's gold, right? Because you can then do a lot of population health management. And just in the context of mom, for example, where mom is being used, right, just by adhering to a protocol-based antenatal care, by reviewing of this data by specialists who are sitting remotely. For example, we are able to show a 3x improvement in early detection of high-risk pregnancies. In our pilots in India, in Indonesia, in Africa, where we are doing this with the help of the Philips Foundation and other partners. And then once you're able to show this data towards the end users who are spending quality time entering good quality data in, then it's that much more encouraging when you show improvement in early detection of high risk, improvement in early referrals to higher centers, improvement in early detection of conditions like anemia, which tend to be leading causes of death due to bleeding. So all of this data then becomes supremely powerful, and then from that level you can go a level up, which is really population health management sort of data, right? And where you start to look at what are the big trends that we are seeing. So for example, is malaria widespread during the monsoon season? Are a lot of pregnant women suffering from that? Then is it widespread in certain particular demographics, within a bigger city? So can we then try to intervene at an earlier date before monsoons, for example, so that we get lesser cases of malaria coming in during monsoon? So those kind of population health management insights become critical. And just on the last point, Ashwin, what you touched upon is working with the ecosystems and the entrepreneurs. And you're right. I think with the Philips healthcare program, the HealthWorks program, we do a lot around working very closely with startups in the healthcare space, particularly startups that share a similar vision as ours, which is to improve lives and improve access to care. And very often, we find that these startups are brilliant at coming up with these innovative, ideas and technologies, and but often sometimes they lack in areas like providing the right channel to the market, whether it's a go-to-market strategy thing, whether it's a pricing thing, or whether it's partnering with the right people in terms of a service infrastructure. How do you support these solutions in a remote area? How do you put feet on the ground, right? And all of that is something that we do through the HealthWorks program, is to let them do what they do best, which is innovate, try to fix some of the other things around the whole ecosystem to see if we can bring these solutions to the market faster, in a more efficient way, in a more price competitive way, so that these have a better chance of scaling up and succeeding.
Dr. Queen spoke about the risk of adopting external technology from other markets, and Jeff spoke about building local capacity, etc. But what is your view, Dr. Queen and Jeff, on how do we make the solution sustainable once the donor support stops? How do we build a sustainable way to keep the innovation going once the seed capital from the donor is out? This question comes from Margot from Philips Foundation. So, Dr. Queen, could you please take a shot?
One of the things that we've learned again over the past several years is government involvement. For a country like Malawi, where we have quite a narrow private sector base in as far as health is concerned, the majority of our health services are actually public. So government is an important player. And then we have these non-for-profit faith-based organizations. And so we've learned over time that if you bring in, you can bring in, loads of technologies as a donation. But if that's not embedded within the government planning documents, government policy documents, they will be used within the lifespan of the technology, and that will be the end of it. And we've been very, very careful this time around. We wish we had learned this about a decade ago, that we probably should engage government at a much, much early phase. So there's been quite a lot of, developing policy that would enable things to be budgeted for. We don't have an endless pot of money, but if something doesn't appear within our documents, our government documents, it will never be budgeted for. So both at a national level, but also at the local government level, because Malawi is undergoing decentralization. So it's been quite a fast learning curve. The other people that we've been working with very, 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 very closely are our major supporters in the maternal and child health field. So people like UNICEF, USAID, WHO, Save the Children, and together we've come up with what we call the new National Newborn Steering Committee that has been tasked to develop policy strategies. We have people from every directorate in the ministry, from planning, financing, HR, and so developing this national strategy for Malawi for neonates. And so we have a draft document. The other thing that we tend not to talk about around the technology field is, what about the supplies and consumables? It's one thing to have a fantastic piece of technology, but if you don't think about supplies and consumables, how do we get them inside the country? Who's going to pay for them? So it's these little things. We have a big headache with distributors in Malawi. And so to get something from outside the country, it can cost you 4 times more, just because the financing market is it's just so tricky in our setting. So working with governments. But one thing that we must always remember, when you're working with government, be prepared to work slowly. And there's always this balance where you want things to move so fast, but if you if you run so fast alone, you will not get far. But if you run together with government and these really important stakeholders, be prepared to go through the pain of the bureaucracy, you are much more likely to get a sustainable program at the end of the day. And they were very, very, very clear that we're tired of projects. We want this in a program mode, and we want ownership. And for the first time, they've allocated 3 national program officers to push this agenda. And so, it's an exciting moment. So, you walk slowly, but you make it sustainable.
Great. Thank you very much. I think that's a very insightful view of how to co-create with the government from the very beginning. Over to Jeff. What do you think from your perspective? You play a dual role of helping define policy, and also on the other hand, as a funder, as a donor agency, one of the largest donor agencies in the maternal and child health space. How do you see this question of sustainability beyond your involvement in the project or the program? What is your thinking of creating a runway beyond your investment?
Yeah, that's a very important question. Thanks, Ashwin. I think there's been a real evolution in the donor and the financing space over the past decade. Years ago, the majority of the support for healthcare was through donor funding or through government investment. Now the private sector is very much involved. There's creative financing, there's contingent financing, and there's also greater recognition of out-of-pocket expenses that consumers pay for. So let me give a couple examples of what this means and how it impacts the situation. I think one of the roles of donors like the Bill and Melinda Gates Foundation is to simplify, to test, to de-risk and innovations so that some of the upfront costs can be borne while we're learning. And then by the time it gets to the consumer, be the individual or the government, that it becomes something that's more affordable. Another thing that we do is we work with companies to do volume guarantees. Bill and Melinda's first real investment in global health was in the vaccine space. And they were very concerned that good quality vaccines were not getting to children who needed them. And so they worked with vaccine producers and pharmaceutical companies to do price guarantees so that they would guarantee a certain volume in order to drive the price down. So that's a creative way of addressing the financial dimension. And then countries are able to afford it more, and they're able to put their own capital forward if it's less expensive. Another creative way is something that I saw colleagues from the Lærdal global health team based out of Norway do, where they are a real entrepreneurial organization and organization that does the development of anatomic models for skill-based learning. And they have developed a buy one, gift one program where the models, anatomic models, are sold perhaps in high income settings at a price point that allows for another model to be gifted to a medical school, a midwifery school in a low income setting. So I think there are many different approaches. This afternoon, I'm attending an event that's organized by the GE Foundation and UBS Optimus Fund. So even banks are getting involved in how they can look at creating value through creative financing schemes. So I think there are many different ways that things can be, the price can be brought down, the product can be simplified in order to get the products and the technologies and even just the programmatic approaches into the hands of governments. You know, Queen spoke about the challenges in the health workforce. I think one of the things is increasing the number of health workers. There's a huge gap in the number of health workers, but we also have to help each one of those health workers be more effective and more efficient in their work. So what can we do in terms of technology or in terms of other support systems that make the job of individual health workers more efficient? We're very fortunate at the foundation that our co-chairs, Bill and Melinda, come from the technology domain. And so while they are no longer associated with Microsoft, they bring the wisdom and the experience learned over many years at Microsoft to the problem solving and the technology thinking environment that we have at the foundation to see if we can make more efficient, make something faster, make something better so that we can get to more people. So I think there has to be a variety of different approaches used.
Great. I think we have covered a whole range of topics in this discussion, ranging from capacity, contextualization, culture, infrastructure, investment, and incentives. I think one question that I would pose to all of you is, what if one thing we could change could remove the key systemic barrier for accelerating access to maternal and child health technology? Maybe I can go with Jeff because you're on screen right now. What is the one thing, what is the magic wand that we can use if we were to turbocharge access to technology-based care?
I think one of the things that we spoke about already is really fundamental and central to all of this, and it's good quality data, because we really have to be responsive to the epidemiology. We have to know what the burden of disease is. We have to be able to track it properly. We have to be able to respond to it accurately, and we have to know whether or not we are achieving results. One of the great areas of discussion in our field of maternal child health is accountability. And how do we manage the domain of accountability if we don't have the data to say whether or not we're achieving or not achieving? So I think improving data systems and making data easier to collect, easier to interpret, and easier to respond to will help drive improvements in the entire maternal child health space.
Dr. Queen, coming from the practitioner's lens, I'm sure you have a very different view, or maybe a complementary view to what Jeff said. What is it that we need to do? Maybe one thing, one big change that could eliminate this systemic barrier.
I think we need to be more ambitious and be prepared to invest. I remember when I had just finished my medical school, at the peak of the HIV epidemic in Malawi, where our wards were full of AIDS patients. And at that time, the talk was, Africa cannot do it. But look at where we are now. With the right investment, with the right frame of mind, we have people that are passionate, wanting to move their agenda. We can do this. And there's never been a better time than now.
I think the main thing is to transform our passive recipients of care into more proactive demand generators, because if people on the ground, if they start really demanding healthcare services solutions, I think there'll be there'll be more of investment, there'll be more of solutions, there'll be more of pilots. Though I don't believe in pilot because it has to be part of the government system, but we have to convert those communities into proactive demand generators, so that they are they are the masters of their own healthcare. They have their own health in their own hands, and it will also give rise to a lot of quality data, obviously, but but they have to be proactive in demanding the services, demanding healthcare, which is most important for us. And we have started a program called Ubering Health, where where in the community we are converting adolescent girls who can take care of a very small group, maybe 4 or 5 groups, and create an environment where everyone becomes a demand generator, and they ask for more and more and more of health.
Thank you, Hilmi. Ankur?
Yeah, Ashwin. So I think echo a lot of the thoughts of the speakers, but for me, I think good quality data coming in is crucial. So I fully with Jeff there. But I think one of the things that really needs to happen, because the largest impact that we can have in mother and child care is through the public health system, right? Because that's, if you look at countries in Africa, Southeast Asia, most of this primary care dispensation is free of charge, and that's where the largest volumes of deliveries and mothers come in, is the public health system. And if you talk to any person who has spent time at that level, you'll hear that maternity tends to be one of the most highest patient volumes, in terms of just the amount of work. So I think we are massively understaffed. So I think there is definitely, it's a human resource problem. And I think we have great digital systems. There are a lot of systems, but we don't have enough people to enter good quality data in those systems. So I think that part of the problem definitely has to be solved. If we can, if we want the digital system to really have the real value that they can add, is to have that human resource problem solved, so we can get good quality data in.
Great. Just to summarize, I think we got some very interesting thoughts, ranging from focus on the data to define what we are doing, and also evaluate how things are. And Hilmi's point on involve the community, both in demanding for services and building capacity to deliver them. And then to link to that, Ankur, your focus on human resources, how do we build the capacity to have more people adopt this technology and deliver? And finally, Dr. Queen's bold call to action to be more ambitious. I think we have a great amount of work cut out for all of us. I want to thank all the speakers for joining us. Such a great conversation. I also want to mention that we have a second webinar coming up in November. We will announce the date shortly, but please do join us. The theme for the second webinar is strengthening the last mile. We have spoken a lot about these things, including building capacity and how do we upskill community health workers. The theme of the next webinar is exactly that. How do we strengthen the last mile? But before we leave, I want to thank our panelists, Dr. Queen, Hilmi, Quraishi, Ankur Kaul, and Dr. Jeffrey Smith. Thanks for taking the time, and all of you for participating from across the world. We hope that this conversation was interesting, and we are certainly looking forward to getting your feedback on how we can make this more useful and engaging for all of you. So thanks on behalf of Ashoka and the Philips Foundation. Thank you and good night.